All right, good afternoon, everyone, and welcome to our Health Policy Summer Series. Excellent. We have an exciting panel today. We have Shawn Martin, who is Executive Vice President and Chief Executive Officer of the American Academy of Family Physicians. Welcome, Shawn. We have Jeannette Thornton, who is Senior Vice President of Product, Employer, and Commercial Policy at America's Health Insurance Plans. Welcome, Jeannette. And we have Peter Bach, who is the Director of the Center for Health Policy and Outcomes at Memorial Sloan Kettering Cancer Center. And our panel today is going to talk about the top priorities for access and affordability in the U.S. health system today. And we're going to start with Shawn Martin. And I encourage our audience to post your Q&A through the Q&A function, and we'll moderate your questions and get them addressed through our panel this afternoon. So starting with Shawn Martin, share with us your thoughts on your top priorities from the view of primary care and family physicians, please.
Yeah, well, Allison, thank you so much for having me. It's good to be with you guys today, and I appreciate the opportunity to share a few thoughts. And it's always good to be with Jeannette and Peter and good thought leaders around the country doing good work. So I appreciate the invitation. So I'm going to summarize my thoughts into kind of what's next for primary care in kind of 5 areas. And some of them are lessons learned. Some of them are continuations of things we knew to be true before the pandemic that kind of carry over through the pandemic and kind of into a post-pandemic healthcare system. But the first one is really a shift in what I would, from an academic perspective, call the decentralization of healthcare, but it's really a focus back on community-based care. And, we kind of had this ramp up where care really centralized into institutions through the 70s and 80s, largely driven by Medicare dollars, but we kind of had this like institutional focus of healthcare, and you saw less and less, the example is always the country doc or the Marcus Welby or, that type of thing became diminished in its role in our healthcare system. And what we've kind of seen is that crescendo and kind of come back over. And there's really a new focus on community-based care models and the role of not just primary care physicians, but other clinicians who are out in the community, social workers, mental and behavioral health specialists, et cetera, that are down Main Street and not necessarily inside a large glass building in the center of town as kind of the focal point of care. And I think this is important. People, get healthcare a little closer to home, a little closer to work. It's not as intimidating, it's more engaging, and it's more continuous. And I think we'll continue to see this trend from a delivery and payment perspective. The second thing, which I think COVID really put an emphasis on, is a focus on health. We like to consider as a country that we always have been really focused on health, but that's just not true. Our statistics do not bear that out. We are a very sick population, and we're an aging and becoming sicker population. And I think COVID really brought into focus for a lot of people health and the importance to focus on health, because people with underlying health conditions, statistically speaking, were at greater risk, when the pandemic and the virus began to spread. So I think the focus on health is really, exciting from primary care's perspective, because they view them, my members view themselves as partners in a journey of health and wellness. And, I know insurers have largely taken on this role as well. They view themselves as kind of facilitators of health and helping people be healthy, whatever that means to them. So I think this focus is really exciting, and we should all celebrate and lean into that. The third thing, which gets all of the press, but I think it's really important, is the kind of the consumer engagement in health, particularly in primary care. So we have had a primary care system for most of my life and all of our lives. If we wanted to engage with our primary care physician, we left work, we went down the street, we sat in the office, and then we had an appointment. And then if we had a follow-up appointment, we repeated that cycle. If we needed to refill a prescription, we repeated that cycle. So what COVID did was basically accelerate the diffusion of technology about a decade. And now engagement with primary care still is a face-to-face encounter in many respects, but it is supplemented by telemedicine, by digital health, by apps, by transfer of information by consumer engagement with their primary care physicians in a digital or telephonic manner, not always in a face-to-face manner. And I think this is really, when I think about the 21st century primary care, it is how these different modalities of care supplement the face-to-face and continuous kind of personal relationship with a primary care team. The fourth one is a trusted source of care. So there's a lot of information out there floating around on the internet. Some of it is good, some of it is bad, some of it is true, a lot of it is false. So primary care really has kind of become a conduit or a place where these conversations take place about what is truth, what is good information, what should I believe, what should I not believe, what is best for me, what is best for my children, what is best for my family. All of this is really taking place at the primary care offices right now, and it's really fascinating. It's very frustrating to our members in some respects, and it's also very exciting to them because they become a trusted source of information or truth. And then the final piece, which depending upon the audience I give is either number 1 or number 5, because I can't decide if it's the most important or the 5th most important, which is just the economics of primary care. The COVID pandemic really showed how the fragility of our primary care system, how we finance primary care, both from payers, employers, governments, but also how individual contributions support their access to primary care and the prevalence of high deductibles and the out-of-pocket costs that drive a lot of decision-making processes for individuals and their families when it comes to primary care. So I think this will get a lot of attention in Washington, D.C., because they tend to focus on the economics of healthcare. But this is really a conversation that's taking place at board tables and obviously kitchen tables. I mean, across the country, how do I access and afford good primary care for my employees, for me and my family, et cetera. So I will stop there. That was a quick overview, but I think those are the 5 things that we're spending a lot of time thinking about.
Thank you so
Thanks,
much.
Allison.
Absolutely. Jeannette Thornton, can you give us your thoughts from this perspective of the health plans?
Yes. Hi, everyone. Thanks for having me. Great to be here with Shawn. Be curious what Shawn's thinking about the recent competition executive order that came out on Friday, because I think it gets at some of these issues. But so I want to talk a little bit about coverage. I think now that we're here in July, we really have a good signal of where the Biden administration is really focusing their policy agenda, both legislative and regulatory, on the issue of coverage. And I think we have seen, and AHIP strongly agrees, just a strong emphasis on a need to finally kind of crack the code in really getting at that 11% of the non-elderly population, that under 65 population that really is uninsured. And from some early signals in the administration, an executive order that was released at the end of January, as well as some other information coming out, we do see that there has been a strong focus on how to get more people covered. Because what we've learned, and there's a lot of data out there, that so many people that are uninsured really do have access to or eligible for either whether it be Medicaid coverage in the individual market as well, or some employer-based coverage. So I definitely think that's really important. One of the things that we saw early on in the administration is for people who don't have coverage through work and who have to purchase coverage on their own, just as a result of all of the unprecedented disruption we've all faced as people here, an emphasis on now is the time to really focus on getting people covered, and the creation of a special enrollment period that's now in place through August. So if you don't have coverage and you want to purchase coverage, you can go to the individual health insurance marketplaces and get coverage for you and your family. And it's something that we strongly supported, and we've been really working to help get the word out for people that there is an opportunity for people to get covered. But along the lines of affordability, another thing that I wanted to highlight is in the comprehensive rescue plan passed by Congress, there were a number of really important healthcare policy developments that I want to highlight. First, for a number of years, we've been calling for ways to bolster and improve the individual market, so it does remain an option for people who are looking for coverage for them and their family. What the rescue plan did is it greatly increased the generosity of those premium tax credits that are available on the exchanges for people to buy coverage. So people earning up to 150% of the federal poverty line can get coverage basically for free, which was really exciting and important to see that be made available. Another really critical thing that they did was prior to the passage of this rescue plan, there was a cap or a cliff and who would be eligible for support in purchasing premiums at 400% of the federal poverty level. And this rescue plan eliminated that, as well as made that an option for people who weren't previously covered. Unfortunately, the rescue plan improvements to tax credits are only in place for 2 years, so for 2021 and 2020. But we've seen strong signals from the Biden administration, as well as leadership on Capitol Hill, that there is active discussions about further extending those improvements, as well as making them permanent, which is something that AHIP would support. Just to make sure, again, that the individual market, it's about pre-pandemic, it was about 14 million people who sought coverage to the individual market. Certainly expect that to tick up with the changes in the tax credits, as well as this ongoing SEP that I mentioned. So definitely think that's really, really exciting for the American people to have that option. The other thing that I wanted to talk about is some other policy priorities that we're focused on and that we've seen carry over from the prior administration into this administration. And you may not know, but sort of tucked into the massive end of the year Consolidated Appropriation Act were a number of healthcare provisions, one mainly being the comprehensive legislation to eliminate this issue of surprise medical billing. I'm sure you or members of your family have experienced the situation where you go to an in-network facility, but you happen to be treated by an out-of-network provider, really through no choice of your own, or you experience an emergency or have to take an air ambulance ride when you're really not in any position to focus on your insurance coverage, right? You just need to be healthy and well and seek that treatment. So tucked into the legislation was a comprehensive set of consumer protections that call for implementation of protections for surprise medical billing starting in January, which in terms of the healthcare apparatus is no short time frame in terms of having our systems and processes in place so that when you're seeking care at an in-network facility and you're treated by an out-of-network provider, you'll see those protections coming into place in January. Just on July 1st, the administration issued its first of what we expect to be a series of regulations describing some of the processes behind that. And if you all have questions, I'm happy to get into that in a little bit more detail. But another topic, and I think Shawn got to this as well, is the issue of transparency. Also included in this massive legislation was some new requirements for health plans related to transparency. One of them I think is particularly exciting, being able to get an advanced estimate of your care before you seek treatment. I think something that has a lot of technical implementation details that we need to all work out as an industry, but can you imagine going to a provider and getting a printout based on your insurance coverage of exactly, hey, this is the services that we're thinking of providing you, here's what it's going to cost you. I think that's going to be very important, but we'll need to talk a little bit more about how to make that work from a technical perspective. Also included were requirements for all health plans to have calculators to ensure that when you're looking for a physician or a hospital or a lab, you can do research up front to see who's in your network and what it costs. Many of our plans have those sorts of tools available today, and this made this a requirement. The other thing that I did want to highlight was a focus on prices and healthcare transparency. So some of you may know during the last year of the Trump administration, there was a wide-ranging rule that requires all hospitals to post their prices that they've negotiated with health insurance plans. But there was also a separate rule that impacted all health plans that takes effect next January as well, requiring plans to post these very detailed files with all of their negotiated rates with all of their hospitals, providers, facilities, drugs, services, et cetera. We have a lot of concerns about the release of these proprietary rates and sort of the impact that could have on negotiation and competition, et cetera. But certainly something that we expect the Biden administration to prioritize. It was signaled in the competition executive order that the president signed on Friday, that it is something that's very important for this administration to make sure that people, when they're shopping for healthcare services, can know what things cost upfront. Just a couple other things to highlight, and then I'll close. We do expect a big focus on coverage, as I mentioned, and we're also looking at a number of other activities, potentially as part of a larger reconciliation package addressing prescription drug costs, which certainly remains one of our large barriers to affordability. I think we're all following with great interest the discussion about Agilehome on the Alzheimer's side, and blockbuster drugs like that continue to be approved and under development. And I think we have to decide as a country, so how we're going to pay for all of those. So I think we welcome the debate on Capitol Hill about prescription drug pricing and how to make sure that there aren't abuses and patents and paper delay and all sorts of some other things. And then finally, just a huge focus on healthcare disparities and making sure that people are free to go to the doctor without fear of discrimination. And we do expect a number of really important regulatory developments on that front, probably either later this year or early next year. So just a couple of highlights, Allison. I'll turn it back to you.
Thank you so much. And Peter Bach, if you could please tell us about what you see as the priorities for affordability and access.
Yes, sure. Allison, thank you for having me. And I think Kettering is going to put up my slides because I brought slides to talk a little bit about the current state of pharmaceuticals and pharmaceutical pricing and what we need to do to address them. Great, thank you. I don't know if I'm in control of these or if you guys are, but it doesn't matter. I'll just, all right. So if we can, setting some context here, I'm ready for the first, or this slide's perfect if you want to leave it here. So let me set some context to think about the pricing in the pharmaceutical market. It was nice that Jeannette mentioned Agilehome or aducanumab, the Biogen product, because it's worth considering when Congress and the president look forward to addressing high pharmaceutical prices, exactly what the problem is that we're trying to address or work on. And so it's worth, for me, the sort of beginning of any conversation begins with the assertion, which I think we lose track of, but is essentially a statement of fact on this slide, which is that Congress created the pharmaceutical market in the United States. And it did it in a very special way and with a certain level of intentionality, based on this idea that drug development is risky and expensive. And so if you are going to rely on a private marketplace, that's not the only way to develop drugs, but if we are going to rely on a private marketplace to develop drugs, well, then money needs to have a return. And if drug development is risky and expensive, that means high cost, long time horizon, and low success rate all combine to suggest that anyone who's going to put money into this business requires a big payoff for successes. And so Congress went about the business of creating an artificial market for drugs. And the centerpiece of that market is the temporary monopoly rights given to drug innovators when they're successful. Next slide, please. So a couple of years back, my colleague Drew Krular and I and some other colleagues described the structure of the pharmaceutical market in very stark or plain or simplistic terms shown in this diagram. And the reason we went about this was to express to everyone our understanding of this market in the way I've just described it, that it was a creation of Congress in every aspect. And that means Congress, it's in Congress's control to fix what's broken about it as well. And so you can think about the time horizon for successful drug development as having this innovation period. Yes, please don't advance. Having an innovation period, that's the first period where the drug company is spending money, which is shown by the spending, the profits being negative during that period. Then a drug is approved by the FDA based on certain criteria. And then for a certain amount of period, the reward is delivered to the pharmaceutical company. It's granted this monopoly, which allows it to obtain very high profits for its drug over a certain period of time until this date ends of exclusive rights. They lose their exclusivity. And then the price and the profits and the vendors for the product all change and profits fall to what is typically considered from economic terms as cost of production. And in this simple schematic, I just want to emphasize that Congress has a role in every single part of this except the pricing. And that's what's probably going to change now. But the idea that there's an innovation period that ends when a drug is approved by the FDA is not a static thing, but instead something enshrined in law. What is the standard for a drug to be approved by the FDA? And Congress over the decades has added different ways for drugs to get approved based on less data, based on faster review times and other sorts of things, breakthrough, fast track, accelerated approval. These are all versions of Congress reducing the time and the risk between the innovation period where the drug company is losing money and the monopoly period when it's making money. It also defines when that monopoly ends, both through patent laws and FDA exclusivity periods, by adding on exclusivity for orphan drugs and things like that. And it also actually controls the entry of competition in both the generic and biosimilar space. Next slide. So to give you an idea of, that's right. And so the only thing Congress does not control is the market. So to give you an idea, this is the right slide. To give you an idea of how Congress changes this reward box, these are the provisions included in the Orphan Drug Act of 1983 that lowered the expense of innovation by giving tax credits, that's reduced the innovation time, or if you will, moved up the time for transition to the monopoly period by expediting FDA review of orphan drugs, and by widening the box of monopoly period by extended exclusivity for orphan drugs. Next slide. Here's an example of the 21st Century Cures Act, which reduced the cost of innovation by allowing some sorts of approval based on observational studies, by expediting FDA review for regenerative medicines. It moved the FDA approval bar to the left in terms of time. And by further loosening restrictions on off-label use, it increased the height of the box by expanding the market for drugs beyond that for the label included. Next slide. So this reward system, no question about it, plays a role in the new drugs we have gotten, but it has been poorly managed. And as a result, there are serious opportunity costs associated with these innovation incentives. And where opportunity costs are the costs we are paying by losing one thing in exchange for another. The classic opportunity cost being you are now giving up a perfectly pleasant lunch by sitting here and listening to me talk, for example. So these opportunity costs are of meaningful consequence and of direct relevance to this discussion we're all having today. Drugs are unaffordable and they have led to the collapse of insurance structures and benefit design. The lack of containment of prices or rational basis for them has meant that value has declined for today's goods, it should say drugs in this case. Access has been impeded or diminished, and spending has risen to a level where it's crowding out other types of spending, both in healthcare and more generally. Next slide. So to give you an example, focusing on cancer drugs where I tend to work. So in a context where prices are poorly managed, prices are not necessarily sensible. And in this example of cancer, on the left-hand side is a graph we maintain on our website of the introductory prices of cancer drugs over time, going all the way back to 1965 when Medicare was introduced. And this graph is in sort of apples to apples comparison, a month of a therapy for a new cancer drug. Each dot's a different drug getting approved, normalized for inflation, normalized for a standard sized adult. And you can see the rising prices over time, and you can see that the y-axis is actually a log scale. So what this graph shows is that adjusted for everything we can think of, prices of cancer drugs have risen about 130-fold since the beginning of the Medicare program. Shown on the right-hand side is declining value, in the sense that all in a standard dollar year between 1995 and 2014, the cost of a drug relative to how many years of life it produced has risen 5-fold over that time period, again, adjusted for inflation. In other words, the cost of buying a year of health with using a cancer drug has become 5 times more expensive based on introductory prices over that time period. So this is an example of a market that is going in the wrong direction, where each incremental benefit to the consumer costs more than the benefit that came before it. It's of course the exact opposite of what you see in highly competitive, successful markets like technology markets, where the incremental costs of computers, for example, can fall in real terms while the computing power rises. Next slide. They also have led to the collapse of insurance structures, which increasingly have benefits that leave sick patients relatively uncovered or completely uncovered, put them in positions where they literally can't afford prescriptions for medications for which there is no risk of abuse and that could be extremely important for their health. This is a recent study from Steve Morgan and Augie Lee showing that the rate of cost-related non-adherence, meaning people not picking up their prescriptions, not completing them in the right schedule, but due to cost alone, is about 16.8% of Americans reporting this, more than the single digits in any other country. And this is, of course, a huge problem, not just economically for patients, but it undercuts the very purpose of drug incentives, which is to lead to the creation of new drugs that improve health. And as people are fond of saying, a drug, no drug can be effective if the patient can't afford it. This is an example where the last mile of innovation, you have a new drug that's promising could improve somebody's health, doesn't do them any good because they have cost-related non-adherence. Next slide. So a lot of people are now trying to advocate for value-based pricing, this simple idea that has mechanical clarity, where drugs, instead of being set by drug companies and essentially unregulated, drug prices, instead prices of drugs would be set based on how well they work. And in doing this, you could balance affordability and innovation. Now, the whole idea here is to use math and health economics to determine a sensible price for the drug, set the drug at that price level, let competition, if it exists, drive it lower. But either way, get rid of the use of high out-of-pocket costs and high deductibles and co-insurance as ways of reducing utilization to save plans money, or alternatively as a counter to high drug prices to extract more rebates, because those are inefficient in many ways. Most importantly, they lead to people either having to pay very high prices for their drugs, which affects them in other ways, or not being able to afford their drugs. The idea for value-based pricing is essentially price setting. It's not using the market. It's neither allowing the drug companies free rein on how much they can charge, nor allowing insurers free rein to use high out-of-pockets and tiering and things like that to counter those prices or move the price of the drugs off their books back onto their customers. So you can, I put here jokingly, it's sort of un-American to think about price setting in the marketplace. But to my first slide, this isn't a marketplace. This is a machine created by Congress to incentivize innovation that can be repaired. and it's better than all the other options. It concedes multiple failures in the market. It makes the prize for innovation even more clear, because if you pay based on how well a drug works, it means a big innovation gets a big dollar tag tied to it. It makes patient costs low when appropriate, even if, meaning the out-of-pocket stays low, even when the price itself is high. And it should seem like that's a pipe dream until you realize that's what every other Western country has accomplished by working at the national level to achieve appropriate prices. And there's obviously a lot to think about here in terms of how you get to the sensible price, but this is sort of the core tenets behind value-based pricing. Next slide. So here's just one example. ICER is the Institute for Clinical and Economic Review up in Boston, Steve Pearson's group, and they routinely analyze drugs both before they're approved and after to see what their appropriate price is. And they are doing this thing I talked about. They're using math and health economics to assess how much a drug should be worth based on what the benefits are. And in this table from their final report, they said the annual price for Agilehome based on the expectation of the improvement it has, based on, as everyone knows, very shaky data on a surrogate marker, the annual price should be about $59.60 to $83.60 per year. You can contrast that with the annual price Biogen says they're going to charge, which is in this first column, which is $56,000. The reality is, if any of you saw the Wall Street Journal, this came out Friday afternoon, so hopefully you did not, but we've just analyzed Agilehome doses across the actual population of Alzheimer's patients, and we anticipate the annual price will be more like $61,000 or $62,000 per person, not the $56,000 the company has claimed. It's a weight-based drug, and the company anchored the price that they've used in all their announcements to a patient who's unusually light, if you will, of low weight, not representative of the population. This is something pharmaceutical companies do all the time with weight-based drugs, and they sort of sneak through much higher prices than they claim because, these things are complicated and it's very rare. We reported this about 5 years ago, and it's a practice that goes on always. Next slide. And so just to bring this full circle, and this isn't a statement of advocacy or anything else like that, I just want to point at some of the projections the Congressional Budget Office did for H.R. 3, the Elijah Cummings bill in the last Congress, where the trade-offs become quite stark. Remember I said early on that one of the opportunity costs we're paying is that spending on drugs is crowding out other things and causing other sorts of declines in health that because of lack of access. The CBO put some numbers around this. And what they found was that if you negotiate drug prices, prices fall, and that first line of $303 billion in savings is a reflection of the reduction in drug prices. But the next line actually reflects savings that would come from reduced spending on other medical services other than the price of the drugs. And the origin of that is that if drug prices fall, use of drugs will rise and make people healthier. And as a result, they will need less medical care. And so this is the CBO sort of weighing in on one of the opportunity costs we are paying for having high drug prices. It's not just that we're paying once for the drugs, we're paying twice because we're paying for the medical complications of people who can't afford the drugs, but we're actually paying in terms of health as well in our population. And as the CBO estimated it, there is a trade-off baked in here. The estimated decline in new drug discovery would be about 3 to 5% over a decade. My prediction here is that that decline would mostly affect drugs that are Me Too drugs, where the opportunity to come in with a new brand and undercut will be affected by negotiation. But the truly innovative drugs will see reasonable prices and continue to be created. When we know that, for example, the CAR T therapies sell in Europe for very similar prices to what we pay here in the US. That's the slides I have today. Thank you very much for your attention.
Terrific. Thank you so much. I'd like to stay on the topic of the high cost of prescription drugs for a moment, if we could. And Jeannette, I know this is a topic that AHIP takes a great deal of interest in also. What are some of the policy proposals that you see in Congress actively being discussed?
Absolutely. Thanks, Allison. And I'm sure others can add on. So, there is, as Peter mentioned and talked about HR 3, there's just a strong recognition, especially on the Democratic side of the aisle, that as part of this massive sort of healthcare priorities package, there needs to be action to address high cost drugs. Now, what actually makes it into the final sort of sausage, through the final sausage making, and also what could pass the Senate, as we know, very close margins, is sort of really an open question. I mean, there's a lot of debate and discussion around some potential changes to Part D for Medicare. There's a lot of discussion around, negotiation in the Medicare market. Again, unclear what sort of makes it across the finish line in the Senate. And there's also a lot of discussion around inflationary caps on the increasing price of drugs, both in the federal program side as well as in the commercial market. So those are just a couple of things. The executive order that the president signed on Friday also has a number of other really important directions to the agencies on potential reforms, whether it be patent reform and other incentives for biosimilars and generics that have been talked about over the last several years.
Thank you so much. And could you, Peter, maybe you can weigh in here, speak to the role of the pharmacy benefit manager component?
Yeah, it's hard to summarize briefly how PBMs play in the prescription drug market. There's not much question that they're probably not offering their customers the optimal products in many cases, where I think of the customers as ultimately payers and large employers. There's been a lot of consolidation in the PBM market, so they probably don't need to compete on product quality as well as they could. They're often held up by the pharmaceutical industry as sort of the biggest problem out there. That's probably wrong also. There isn't much question that the techniques they use, although they partially use them to enrich themselves, they don't keep that much of the money. We had an analysis a couple of years ago in 2017. I want to say they were putting in their pockets about 4% of total drug spending or something like that. I'd have to look it up, but it wasn't some monumental sum. And there's no question that their approach does work to counter just sort of unrestrained spending, which is why when the Trump administration proposed lifting rebates, a rule that's now on hold, total drugs projection was that total drug spending would rise. You wouldn't have this other actor in the market trying to get discounts. But the structure of insurance and benefit designs they propagate in the prescription drug market is harmful to many patients who don't have the financial ability to buy drugs or pay for drugs that they need or that can benefit them. It's indiscriminate, and that's why I mentioned that there's a lot of drugs and cancer, stuff like that, that are not really drugs of abuse. No one is buying an oral chemotherapy to resell it on the street. No one is buying it for fun or because it gives them a high. There's just no economic theory by which forcing patients to pay enormous co-insurance on those drugs has any rational basis, except it saves the plan money. It can be used to get lower prices. And that's one route they save money. But the other one is they know patients won't get their prescriptions, and so they won't have to pay for the other piece of it. And that is not a structure that engenders like the maximum health gains.
Thank you. So Shawn, let's turn to primary care for a moment, because as you mentioned, as a consequence of the pandemic, we've had an enormous shift to telehealth. We have new telehealth codes, Medicare was extremely creative in bringing in remote patient monitoring, or not calling it telehealth, but being able to incorporate some remote patient monitoring, reimbursement, chronic disease management reimbursement. And then we have the recent revised physician fee schedule, emphasizing the non-proceduralist, the outpatient evaluation management visits, particularly established patients, over the proceduralist codes. So what do you see all of this meaning for primary care? Is this a big deal for primary care, or is this not going to help us move forward on burnout issues?
Well, I mean, I think all of it is positive, and I'll be, completely glass as full. I think anything that creates or supports longitudinal or continuous care models and enhances connectivity at the community primary care level is a really good thing. I think the interesting thing to me from the pandemic was, for years, I have spent a lot of my professional career, begging Jeannette and her colleagues and CMS to pay for phone calls. Like, phone calls are really, really important. And sometimes a 5-minute phone call is, really all you need to take care of a patient, or to check in on a patient. And I think the pandemic helped us all just kind of focus on, maybe that's true. Maybe these kind of low acuity, low intensity interventions are really important. And we should think about how to do that. So I also am a person that really finds little value in fee-for-service as a comprehensive payment model for what I consider to be comprehensive primary care. I think comprehensive care models need comprehensive payment models, so we don't have to have these discussions about whether we should pay for a telemedicine visit, or a phone call, or remote patient monitoring, or bring them into the office. We should pay primary care to provide comprehensive continuous care to a attributed population. We should do that in a more thoughtful manner. I think the other part of your question about kind of what the fee schedule as a motivator of innovation, the fee schedule was designed in a different time. And I spoke earlier in my opening comments about kind of this, decentralization of care models and community care becoming more in vogue, if you will, with payers, with patients, with physicians, et cetera. And I think the fee schedule is solely designed to promote to value and promote episodes of care, and more episodes of care, and more episodes of care. It is just a volume-based payment model, and that's okay for some disciplines of medicine, and that's not okay for others. And I think what I would suggest to the audience is, if we really believe in comprehensive longitudinal primary care, fee-for-service is just incongruent with those goals. And even though CMS is taking significant steps to invest more money into primary care, they're still investing in a 20th century construct instead of kind of being thoughtful about 21st century delivery and payment models.
Thank you. So, Jeannette, health plans also leverage the fee schedule and typically use a different conversion factor, and sort of rely on the fee schedule as a backbone. A lot of research went into the fee schedule. That's a sort of a public good, if you will. But where are we in terms of value-based purchasing, and where are health plans in terms of the fee schedule, value-based payment? Is Medicare going to continue to take the lead in most cases, or how do you see that evolving? What do you think from the health plan perspective needs to happen next?
So thanks, Allison. So I wholeheartedly agree with Shawn about the need for changes and moving away from fee-for-service, and definitely strongly support a lot of the flexibilities that were put in place for telehealth, that they're continued beyond the pandemic. Because I think, like as Shawn mentioned, we really have learned a lot, and we can't go backwards, right? This needs to be part of the regular expectation of how that comprehensive care is delivered. But Allison, to your question, so this is a little bit out of my wheelhouse in terms of what I do every day, under full disclosure, but I think we've been really working with our plans and tracking all the different things that they're doing to incent value-based payment, working on standard quality measures with a number of partnerships that we have, as well as really supporting our plans in what is needed to make that transition. We do a comprehensive survey with the Medicare Learning Action Network every year, where we have data that sort of shows the percent of the spend and how it's moving from fee-for-service to different value-based arrangements that you can look up on CMS's website. Is a really good indication of the direction that where we're going. I will say, though, that there are some remaining challenges, especially when you look at trends, especially in rural areas around hospital consolidation and some different market dynamics that come into play that really put some challenges related to affordability. I think that we have to also look at in tangent with, so it's sort of a carrot and a stick. From a carrot perspective, I think incenting greater movement to value is so important. But I also think that from a competition perspective, steps need to be taken to make sure that there is more robust competition in the market as well.
So Peter, from your perspective, do we have the laws in place to allow the value-based purchasing that we might want to have, and it's a regulatory issue, or do you see this as an area where we need additional legislation?
It's an interesting question. So I think on the federal level, there's probably a lot of ability to do on the Medicare side to do more value-oriented contracting and things like that. I think there's a lot of license has been taken with the construct, though, and it's I actually think it's an interesting question how much. I know it's sort of in vogue to blame fee-for-service for the discoordination in the healthcare system. And what I'm not sure of is if that's really the cause of the problem, or if it's simply that any system we put in place will be, profit, that people will act in profit maximizing ways. And so I'm not sure. I can certainly think of examples where fee-for-service kind of works against the interest of comprehensive care. I could also think of versions where it's a perfectly reasonable financing vehicle if things are coordinated at some other level. On the drug side, I think the opportunity for value-based purchasing and pricing is lies in the stuff I presented, which is that, and it's not my work, but just that within the context of finding appropriate drug prices based on efficacy. The pharmaceutical industry has been quick to rejigger this into something which is the public financing their R&D, essentially. Charge whatever price we want, let products on the market that we don't know how well they work, and then if they don't work quite as well as everyone thought, we'll give you some of your money back eventually, maybe. Which is not about value, it's about moving the performance risk of products onto the taxpayer.
Allison, may I say that I agree
Absolutely.
with Peter? I do think fee-for-service has a usefulness, and I think it has an appropriate use. I was speaking from primary care. I think longitudinal care models like primary care are better supported by longitudinal payment models. So I just want to.
I know, Shawn. We don't disagree. I think, I think the issues, I'm just not sure it's the cause of all the rot in the healthcare system. That it's certainly not it's not necessarily the most efficient. Just like the DRG system for hospitals has caused all sorts of weirdness too,
Right. Completely.
Right. And we also have new devices, the glucose monitors, the digital watches. Do you see our reimbursement system adapting to those, or how do you see primary care wrestling with this in their practice?
Well, I don't really know how to answer this because I just have no ability to kind of know what take-up would be, and I think so what I spend a lot of time telling our members is that primary care in the future will be a higher level of engagement than it has been in the past. It will be more real time. I have no idea what that truly means underneath that talking point, but I believe very passionately that it will be a continuous engagement. Patients will be more engaged in their healthcare, and there will be more data to sift through with respect to providing care, particularly for those with ongoing health conditions. What I don't know if that's a Fitbit or an Apple Watch or this like AFib monitor. I just have no idea. Second thing I think is I'm telling our members to embrace that. The more you engage with your patient population at primary care, the more value you're providing to their health and maintenance of health and that longitudinal relationship. And, things will kind of fall out and we'll figure out how to pay for it. But I don't know. It's a mystery to me. And I mean, I think we're just in reactive mode in some respects.
Right. It'd be interesting to see how it impacts a burnout issue that has come up in the context of primary care as well. What about your members, AHIP? How are they sort of coming at the telehealth codes, of course, but this sort of broader patient monitoring world? What's sort of top of mind in terms of the health plans and coverage, affordability?
Yeah, it's a great question. And there has certainly been a lot of change. I think from our perspective in really wanting to look at ways to incent alternative sites of care, alternative ways to access healthcare is really important. I think our plans are looking at whether it's accurate, efficient, is it really the best mode for people? Do they actually need to have that conversation with a provider to be able to understand their results? So I definitely think there's a lot of innovation in this space, and we're learning a lot. I think I give another good example. This is not necessarily primary care, but for people on dialysis, you've seen a lot of innovation for people not necessarily having to go to the dialysis clinic down the street and getting that at home. And those are certainly the kinds of things that our members do want to incent. As a good example, it's probably more affordable. It's better for the patient and not having to find transportation and get there, et cetera. So these are all things that are really, really important for us to be looking at.
We also had a question here about the surprise billing provision. So we've had a surprise billing law in Virginia that took effect in January. And I think the question is, so this impacts your radiology, pathology, the folks that you can't choose as an inpatient. What about on the outpatient side, anesthesiology, similar? And are your plans having to renegotiate their out-of-network rates in anticipation that some of these providers will be paid less if the procedure happened, or if the visit, procedure, whatever it is, the service occurs and falls under the surprise billing provision?
Oh, geez, an easy one for the end of our session here. I'd be happy to come back and talk at length about the new rules and what they mean, but just in a really short nutshell, the law is really getting at two common scenarios. One, you have an out-of-network emergency, and two, you're at an in-network facility for this elective care. You're having a baby, you're getting a knee surgery, getting a routine procedure, and you happen to be treated by an out-of-network provider behind the scenes. And for those providers, they're called in the law ancillary providers, so anesthesiologists, radiologists, neonatologists, pathologists. So they're covered by the law. What that means is you as a patient, you're only liable for what you would have had to pay in network, and the provider cannot seek additional funds. They can't balance bill you, if you will. And all of the actual payment gets hammered out behind the scenes through a new process and rules that sort of govern that. So from a patient's perspective, your only liability is in network. Now, for that out of network care, you want to go to a world-class cardiologist, or you want to go to you want to go out of network. What the law does is it puts forth this new consent process that provider out of network has to tell you that you're out of network, what your costs may be, and you have to affirmatively sign a consent, and that governs whether or not you're protected by the law. So it's kind of complicated, but that's how routine kind of provider surgeons or so would be covered under the law, depending on whether you consent or not. Whereas sort of those behind the scenes providers that you don't even know the name of the person, you're automatically protected under that. But we can talk more about that. We're just digging into the 400 pages of joy.
We'll give you time to read it first. Right?
Exactly.
One of the pieces of the policy paradigm around access and affordability, or certainly affordability, has been transparency. We have transparency in physician quality measures and hospital quality, and now more on the pricing side. So, Peter, what else do we need to do for transparency? I know you've taken interest in transparency around hospital outcomes related to cancer mortality. So, what else do we need to do you think, in the transparency space to move affordability forward?
Yeah, I'm a radical transparency advocate, if you will. I think a lot of what goes on the hospital pricing side, on the negotiations with providers, certainly on the prescription drug pricing side, is inefficient, and that all the confidential prices are not producing social it's not making society better off, it's making the intermediaries better off. And as I noted, I think it's a fundamental defect that we have a system where pricing shifts burden to patients to such an extent that patients are essentially financially blocked from therapy. And I'm not some Pollyanna. I don't think every drug will save somebody's life. I don't think every procedure is needed just because it's performed, but we have just too many examples where it actually is crystal clear that somebody needs something to live, or something would clearly improve their health outcomes. Insulin for a diabetic, Gleevec for somebody with CML, where we see these people being blocked because of financial obstacles. And I bring this up in the transparency context because those are actually secondary manifestations of confidential price negotiations. And I think the real question is, can we clear out some of the cluttered price discrimination, which is about local profit maximization, not about making markets more efficient, and through that actually lower the cost of healthcare and at the point of care. And so I think the quality thing, which is how you teed this up, Allison, is more complicated. But I do think there too, we should be pushing and pushing and pushing to try and produce more and more quality insights and outcome insights. And as we do it, we need to improve methodology and robustness, but we've been probably too cautious, too process measure oriented. We've been, in the face of a lot of data that process doesn't necessarily predict outcome, and try to, make things work so that better transparency on outcomes yields both a signal to patients about where they should get their care, but more important, a signal to providers about what is achievable, so we get a leveling off of quality.
Excellent. And with that, we'll close it. I'm sorry we can't get the perspective from the physician side on some of the initiatives we've had around quality reporting. We still have a long ways to go. I'm sure we can all agree. Well, thank you so much to this panel. It's really been a wonderful discussion. I really appreciate it, and have a wonderful afternoon.
Thanks so much.
Thank
you.
you. Bye-bye.